الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. Good morning everybody, and I welcome Professor Anish Bhatti, and we are grateful, all of us, all of our residents, for him to take out his time from his busy schedule and show his interest in teaching. He's always interested in teaching, always. For the last 25 years I know him. But he has taken out his time and continue the third series of DDH, Developmental Dysplasia series. So I welcome all the participants, and I request other participants to kindly mute their mics. And Dr. Anish Bhatti sir. Yes, sir.
Thank you very much. Thank you very much, Dr. Ziauddin University faculty, especially to Professor Suhail Rafi and others for inviting me for this lecture series. And this is third lecture in the series, and we are today discussing the open reduction principles. Before that, we are up to the closed reduction and arthroscopic reduction and screening protocols. And the fourth lecture will be case discussions and Degas osteotomy and the pericapsular osteotomy in older age children. Today is the principles and protocols for open reduction, and we have the faculty of Ziauddin as well as the expert, Professor Mansoor Ali Khan from Indus Hospital, Karachi, and Professor Shahabuddin from the Peshawar. I'll always say when the DDH, if it is undetected and remain as such, even if the adulthood will not produce a great problem, except the hyperlordosis and the mobility problems, little bit mobility. But if it is mishandled or mistreated, either with the bracing, conservative management, or the operative management, it will produce a devastating complications which remains lifelong disability. It will produce like this has a Pavlik harness injudicious use for more than 1 year and cause the disappearance of the caput femoris. And in this case, when the traction management was given and at the age of 33 years age group and had multiple surgeries, but not in the principles, and last surgery was again with the traction management and the derotation, and ultimately today she is more than 24 years but not able to walk, and she has a lifelong complication of osteoarthrosis, and she will need now the total hip replacement. That's why I say if it is mishandled, it will lead to the devastating complication which remains with the patient lifelong. So today I will discuss what are the principles of the management. Closed reduction we have discussed. Now the open reduction principles and the protocols we will discuss. We will discuss the indications, approaches, steps of the open reduction regarding cateral test of stability, which we do operatively to get the knowledge or the decision regarding which osteotomy further, pelvic or femoral, has to be carried out. And then we will show you the videos on the test of stability, pelvic osteotomy. These 3 videos are already available on my YouTube's, which I will give you the link, but detail we will discuss today. So if the principles are followed, more than 4,000 years these arches are maintained without fall in the Lebanon and the Beirut. But if you don't follow the principles, they may fall down and you produce a devastating complications. So basic principle, the first principle in the DDH is to achieve an anatomical, concentric, stable reduction without a significant pressure on the caput femoris, femoral head, which may lead to the AVN, or a reduction which compromised reduction which may lead to a resubluxation or dislocation. So to achieve anatomical, concentric, stable reduction without a significant pressure on the femoral head, without the risk of resubluxation and AVN, is the basic principle of management. So objective, why anatomical concentric reduction? Because when it is anatomically reduced, the femoral head produces a growth stimulating effect on the acetabulum, and the acetabulum along with the weight bearing on the femoral head, they produce a mutual growth stimulating effect of the femoral head and acetabulum to develop a normal hip joint to prevent the further progressive deformation of the element. When it is eccentric reduction or in compromised reduction, it produces a deformation which produces a disability which may be lifelong, and it will produce a later early degeneration. So to prevent this progressive deformation and early degeneration is the most important objective, And the goal is again to achieve a painless mobile hip at adulthood, at the maturity, because it is seen in the DDH, most of the complication like the cosa vera, cosa velga, cosa breva appears 20 years after the closed reduction or open reduction in the younger age groups. Therefore, it is said the goal is to achieve a painless mobile hip at the maturity. So how to achieve this? This is the particularly a rational approach, which may be a careful clinical radiological evaluation and accurate planning to get an effective treatment for the DDH. And this can only be achieved when the treatment is tailored according to age group. In which age groups, one day, 1 year, before 1 year, they are coming to you, after 3 years, after 8 years. Because the acetabular cartilages, which are triradiate cartilage and pubic symphysis, they get stiffened after 7 years of age group. So it is said that all the treatment for the DDH, which may be open reduction, should be completed before the age of 7 years and 5 years. But best option is the gold standard period is before the 18 months of age, before the patient start crawling. Then other factor is the severity of dysplasia. Where is the femoral head? It is subluxation, total dislocation, height of dislocation, how up it is, and the acetabular abnormality type of the double acetabulum or an obtuse acetabulum. And third is the test of stability, which should be done at the time of open reduction to know the decision regarding the pelvic or the femoral osteotomy, which may be needed to achieve a good initial reduction. So these factors needs to be considered when you plan for the treatment. So if you consider the age groups, it is very commonly studied thing, and commonly it is well reported in the literature that when the younger the treatment, best is the hip joint you will get at the skeletal maturity. The important article which are Ziauddin and Orthopedics were published in 2000, and later many publication comes which shows the AVN low and redislocation rate is minimum. That is 90% best result you can achieve when the reduction is done before 2 years of age. But when you do the reductions, initial reduction at the 2 to 4 years, the best results without minimum complications is the 80%. As the age increases from 4 to, it is 60%. But after 8 years, when the triradiate cartilage is stiffened and symphysis is stiffened, the less capacity of acetabulum to expand, the results become 50%, less than 50%. So the best result to achieve at maturity are when the treatment is done younger than. This is a very important study of the Ponseti and Lindstrom and Wenger in the 2079. They studied 148 cases and say when you reduce the hip joint by the close reduction, you get the lowest final best acetabular index. But when you do the treatment over after 2 years, the obtusity is highest at the final results, means the acetabular index is high in when the treatment is getting late after 2 years. Another study which is very important, study of Lumen and Scott's. They indicate particularly when sometimes patients comes to you and don't see the caput femoral physis, and you wait for to develop the caput femoral physis. This is very important article. Those people who deal the DDH must read this article, which shows if you wait for the development of the ossifis nucleus for over 1 year or over 6 months, when it appears, then I will do the close reduction or open reduction. It doubles the need for future surgeries. It means that you have reduced it. And you can see the good initial reduction at this stage, but later, after 8 years, you get the other complication, cosa vera, cosa velga, or obtusity of the acetabulum, and secondary surgery is required to get the excellent result, further excellent result. So when ossific nucleus is not even there, you should do the close reduction or open reduction at what time the patient comes to you. Should not wait for the dislocations. And this shows the results are percentage of the second surgeries, reconstructive second procedure. Means you are doing the acetabuloplasty for the less uncoverage or not a good initial varus osteotomy, you are doing for the casa velga. So this shows when the reduction is done after 6 months, there is 33% of the second surgery is required at near the adulthood, and so as the age increases, the percentage also increases. This is an important article to read. So the protocols for the treatment should be tailored number one stage is the age, then is the height of dislocation or dysplasia, and third one is the test of this. So principles of treatment are not significantly different than those we observed in the newborn treatment. That is the good initial reduction by the bracing we should achieve, particularly the anatomical concentric reduction without significant pressure on the femoral head. So this principle remains the same, but the protocol for the treatment or the stages or the type of treatment varies as the age increase over 1 year, over 2 years, over 3 years, over 8 years and onward. So protocols little bit vary in the treatment, even in the open reductions. So if your patient comes to you from the day 1 to 6 months, you always reduce it with the close reduction and then give the pelvic harness. But if the child comes after 6 months, when his hip become little bit stiff and irreducible, if it is irreducible, the best option here given is the fixed splints, which are the Craig splints and the Van Rosen splints and the Boston brace you are using. But if it is not even reduced with this, then you have to go for the close reduction with the adductor tenotomy, which may be direct close reduction, or it may be with the assistance of the arthroscope. And some people use after 7 months or 8 months of use the medial approach, Ludloff approach, or the Weinstein approach for open reduction, which is less injurious than the full-fledged open reduction by the Smith-Peterson or Somerville technique. So it is said when a golden age is 6, you must get 6 months to 18 months is the golden period. You must achieve the reduced hip and the mobile hip concentric without pressure before 18 months of age. That is considered the working age group. And you must also observe when you give plaster by the Ramses method of the safe zone, that is not less than 20-degree abduction and not more than the 70-degree abduction for the position of the abduction and flexion to be achieved. So when the patient, these are the certain literature review which shows if the age group over 6 months is with the failed hip abduction brace, the currently preferred method is the close reduction under general anesthesia or arthroscopic assisted close reduction. And the people in the West, particularly in America, do the MRI to see the vascularity, to see the reduction, or to see the interposition of soft tissues. But you can do the arthrography to confirm whether initial reduction is good or not good. And the few literatures are also available, particularly in 2007 and 2005 onward, those who do open reductions with the Ludloff approach or a Weinstein approach, and Mansoor is also doing the Weinstein approach with the successful results. But the other slide shows the AVN ratio goes up to 69% when you do the medial approach, and this may cause this medial circumflex artery injury. And this was the 2019 article of the Kozomi, which showed the 43% AVN in medial Ludloff approach. And this AVN reduced significantly if you do the arthroscopic reduction, arthroscopic assisted reduction with the two portals which we have already discussed, in which there is a minimum chances of damage to medial surface complex and the minimum chances of AVN. So, and further, another study of ESMIC 2015 and Jade indicate that when you reduce the hip, you may have caused some injury by the capsulorrhaphy, tight capsulorrhaphy or tight reduction, which does not appear at the time when you are observing the X-ray evaluation, but it may appear later in the adolescents group. It may develop a cosa valga, cosa vera, cosa brevia. That was which we already discussed, the secondary procedure for reconstruction procedure. But the Zade, the Bachi, the Sitalek, the Kelly, all in the Campbell, all they recommend that if you can delay deliberately to reduction up to the 1 year, it is the best option to do after open rep. But it should be tailored according to pathology as well. If the hip is tight, you can do early stage. But the best is the close reduction, assisted close reduction. But if you can wait with up to the 1 year to at least have a good mature femoral head. And in this case, they have given the results after 2 years. Up to the 2 years, the 94% good result, which was slide which we have already shown to you. So this was the current review of this. And when child comes to you after 12 months to 36 months, 3 months, I would say the 30 months particularly, because after 30 months, he become more stiffer. The method of the protocol of the treatment is the open reduction. So open reduction with or without femoral rotation osteotomy, and this judgment for the pelvic and femoral osteotomy you can do on the radiological elevation. The best is to do the cateral test of test of stability, aid the when open reduce, and do the cateral test we will discuss in detail. And then here you release all the soft tissue offending contractures. It's correct. You need to correct structural abnormality like cosa valga, antiversa, and acetabular dysplasia, and to solve all these problems in single stage. The best previously it was, if you read the literature of 60s of the Mackay and the Pemberton, they recommend the second femoral osteotomy after 3 weeks or 6 weeks. But today it is said that all these procedure must be done under same anesthesia. Do not give them the gift on every single birthday. And here it shows the open reduction in the fast capsule, thick fast capsule, and antiversion. So you have to reduce all this, deal all these hip problems at the single operative procedure. So next was the after age, it was the height of dislocation and the obtusity of the acetabulum, whether acetabulum is regular and how much index is there, or it has a double acetabulum, like this case, a false acetabulum and a very obtuse acetabulum with the 45-degree angle. So you assess pre-operatively and at the operation during to see the test of stability, and this shows the test tonus height of dislocation. It is very well reversed when these two lines are Perkin line and this vertical line is done. If the physis or the metaphysis inferior medial, it is okay, but it is subluxated when it is lateral to the vertical line, and when it line the femoral head physis is at the ridge, at the edge of acetabular ridge, then it is called type 3. And then type 4, when we call it a very high dislocation. And then there is a universal classification of hip dislocations. Many other subgrouping is also discussed. So in this way, you need what to be done. If this is very high dislocation, usually this require a femoral shortening osteotomy, and this is mostly in the older age groups, while these three you can find in the before 30 months of the age groups. So then there is a severity of dysplasia. How come you know the severity of dysplasia? It means the pathology of the dislocation, why this dislocation has occurred. As in this case of this the myopathy, she has a subluxated hip, and this myopathy may cause a redislocation with this type of high dislocation. So tight hips are mostly in the cerebral palsy when there is a spasticity. And then the teratogenic hip like arthrogryposis multiplex congenita. She has the arthrogryposis of elbow contractures, the knee contracture, foot contractures, and the dislocation. So the muscles here are very tight and fibrotic. Therefore, it is called the tight dislocation. So in this dislocations, you need a femoral shortenings and proper the correction of the acetabulum and the rotation of the hip joint. Then there are paralytic hips. The muscles are not, abductors are not good. So it may cause a second subluxation. So therefore, there needs a good acetabular coverage. And the common indication is the failed close reduction and the persistent disability despite of the close reduction. So this is the treatment according to the pathology. Now we are moving to the procedures of the open reduction and what are the objective. Objective we have already discussed, that the anatomical concentric stable reduction without risk of resubluxation and AVN to prevent subsequent deformation of the hip joint at adulthood. Objective and goal is you have a normal, mobile, painless hip at the adulthood. And that has to be achieved when there is an anatomical concentric reduction without pressure on the femoral end and risk of subluxation. So you must have good initial reduction, and this can be achieved when you release all the soft tissue obstacles, where you correct all structural abnormalities, and all this procedure has to be done as a one-stage combined procedure. So here it shows the muscles which are contracted is the iliopsoas, which you can find, and this iliopsoas also produces a dumbbell effect. This is the ढोलकी जिसको कहते हैं. This is the dumbbell effect of this tendon of the psoas. This is the dumbbell narrowing constriction, narrowing our structure of the capsular in the center of the dislocated hip and the true acetabulum. Then when this is dislocated high, the rectus femoris also becomes tight. The adductors which arise from here, they become tight. The tensor fascia lata and hamstrings also get tight, but when they reduce, they don't need anatomy because, and the thickened capsule, which may be a dumbbell appearance. So short adductors, rectus femoris, hamstring, and gluteus and hamstrings particularly get corrected itself when they are, because it is said the gluteus become wrinkled and horizontal instead of in the contracture. But the contracted is the tendon of the iliopsoas, then the tensor fascia lata, which arise from here, and the rectus femoris. These are three more important structures which needs to be released, and without that release, you cannot reach this to deal with this construction of the capsule, because this is very important, and this capsule is not only constricted but very thickened. And then there is a soft tissue interposition in between. There is the labrum, which is inverted, the ligamentum teres. I will show you in the next slides. The ligamentum teres become elongated and thick, and when the space is open, then the fibrofatty tissue in the acetabulum, which becomes very thickened, and we call the pulvinar. So all these soft tissue structure has to be tackled when you are doing the open reduction. At the same time, if the older child is there, you must know perioperatively what is the antiversa of the rotational deformity, antiversion of the femoral head. This is the femoral condyle, and this is the neck. This axis shows the antiversion of the femoral neck. And not only the femoral version is there, but there is a hypertrophied femoral head, and the head is elongated vertically. It looks like an acorn seed of the oak, and hypertrophic overhanged femoral head, and the flatten on one side, which commonly it shows the acorn type of femoral head. So if these findings are the cosa valga antiversa in child and older age group, that needs also to have a tackle down these structures by the derotation osteotomy, and if it is tight hip, with the shortening of the femoral shaft. So now I goes to these approaches which are usually commonly used in the open reduction. Common approach in the group after 1 year or 18 months is the Somerville technique with the bikini incision. This is incision along the inguinal ligament. And other we commonly use is, because some limitations are there for the approach, particularly exposure, then we use the Smith-Peterson iliofemoral anterior incision. And in the older age group, we use the lateral incision, lateral box for the femoral shortening. An advantage of this Smith-Peterson is the greatest versatility as the age group, easily approachable anterior, superior, lateral structures, and the pelvic osteotomy, which can be done with the minimum chances of AVN. Then there is in the younger than 18 months age group, particularly starting with less than 7 months of over the 7 month of age, anteromedial approach of Weinstein and Ludloff approach, which is also done over the age of 7 months, are the Ferguson approach. Both are the medial approaches, which both all three goes between the space between the sartorius and adductors, and then some goes anterior to the gracilis, other goes pectineus muscle, other goes behind the pectineus muscle. So there is a little bit difference, which is commonly used for the medial approach in younger age group. But here the Koizumi in 2019 shows, particularly with the Ludloff approach, the 43% of the AVNs as compared to the anterior approaches, which we do after particularly 1 year of the age. The choice actually depends on the experience of the surgeon and particular dislocation, what type of dislocation, height of dislocation, or the pathology. So here is the Somerville technique. We go the incision from iliac crest to the pubic ligament up to the pubic symphysis, incision which is not visible even after the done in the adult age group. So that's why it's called the bikini incision. And the further steps are same as in the Smith-Peterson approach. Here we do the release of the sartorius, and I will show you the steps. And the incision for the Smith-Peterson arise from the middle of the iliac crest and then anteriorly along the femoral shaft, and taking care of the anterior lateral cutaneous nerve of the femur thigh. And this incision is versatile incision, very big, very easily approachable structures we will find. So here shows the structures, the capsule, dumbbell, and this is the psoas muscles. This is the ligamentum teres, which is thickened, and this is the constriction band, which was produced by the tendon of the psoas, which is shown here. The femoral nerve psoas, which is retracted. Again, the structure capsule is inside, and you can find true acetabulum is there and the false acetabulum is there. So there is a constriction bed, the capsular constriction, the rectus femoris you have to release from here, and the iliopsoas tendon you have to release. And this is the Somerville technique, details of the Somerville technique, which shows the constriction of the bend, and this is the femoral head, the false capsule. This is the psoas tenotomy, adductor tenotomy, and rectus femoris has been released, which is shown here. This is rectus femoris, and then the T cut in the capsule is given. After T cut, you find the ligamentum teres, which is very thin, and this is the pulvinar, which is there, which is hypertrophied fibrofatty tissue. And then ultimately you do the capsulorrhaphy, which is double bracing capsulorrhaphy. It means you have to bring this flap, particularly superior, I say the superior anterolateral flap, after the inferior flap you've done, and the double bracing to cover the good acetabulum containment by the good capsular. Professor Z.K. Kazi used to say me, when you do the capsulorrhaphy, you keep your leg internal rotation, you will get the good capsulorrhaphy attachment, and then the reattachment of sartorius and the tensor fasciolata over the ridge of the physis. So it was the anterior approaches, and these are the medial approaches. Little differences are the approach goes there. There is sartorius muscle, this is adductor longus muscle. Ludloff and Weinstein both goes anterior between the sartorius and adductor longus, then they comes to the pectineus. If you go anterior to the pectineus and neurovascular bundle, this is called the Weinstein approach, and it is a direct approach, and there is a medial circumflex artery which can be protected by the detectors. And Ludloff is same between the adductor longus, and then you will find the pectineus, and between the pectineus and abductor brevis you find with the finger dissection, and here is the circumflex artery finger dissection, and the by detector you place, you will directly go to the lesser trochanter here. When you reach the lesser trochanter, you have to do the tenotomy of lesser trochanter. So you give the structure, and the Ferguson is behind your adductor brevis. It is between the adductor brevis, it goes behind the adductor longus, and then between the abductor brevis and adductor magnus anterior. Here obturator nerves you can find, and you can protect by the finger dissections and placing the rotators. Objective all these three approaches is directly to the medial to go the lesser trochanter. Why to lesser trochanter? They can give the incision like this, they can give the incision like this, and when you reach directly there, you can find the adductor. This is the finger dissection, and this is again the plane between the gracilis pectineus. This is the pectineus, and the adductor longus and the gracilis in between. And after finger dissection, you reach the lesser trochanter. When you reach the lesser trochanter, you detect, you do the tenotomy of the psoas tendon from here, and later you attach this tenotomy to the anterior capsule. Once you do the tenotomy of this, you can find easily the capsular construction here, this is the capsular constriction, and you give the incision, and this is the inferior medial approach particularly, and you find the ligamentum teres, transverse acetabular ligament, which you need to cut. Ligamentum teres, maybe you can cut it or save, depends on this hypertrophy. The pulvinar you will remove from here, and then the capsular constriction you already have done, and then you can also do the further tenotomy. This is pulvinar rectus femoris release from this approach. And then you got easy reduction under the image intensifier, and you give the plaster like this again in the frog-like position. So these were the approaches regarding the Weinstein approaches, which is anterior to the pectineus. The Ludloff we have already discussed, and these are structures which already shows when you reach there, there is circumflex artery here, you have to protect, and then the capsular constriction you need to remove, and then the pulvinar you have to remove, and then the rectus femoris you can do, but you cannot do the Salter osteotomy from here. So this is the stage regarding the approaches. Now, what is the test of stability? Why we are going to do the test of stability? Third step is the test of stability, and this shows the test of stability details. I will discuss what is the, when this is in the neutral position, the head comes out. When the head comes out in the neutral position, and then we further test which how the head is stable. So this has to be done after capsulotomy to know whether this child is needing acetabular coverage or it needs a femoral derotation osteotomy. So it is to identify the maximum stability of the hip at European reduction, to evaluate the need for an appropriate osteotomy, which may be a femoral or the pelvic or the both. This can be done clinically when you do the test of stability. So these are the details of the test of stability. When it is said the hip is stable in the neutral position of weight bearing, then there is no need of further osteotomy of femur or the pelvis, and it is mostly in the younger age groups and in the 27% of population. And here they show how the capsulorrhaphy double bracing is done, and after this double bracing, this has become stable. And usually if it is done below 2 years of age, they don't need a secondary procedure of the reconstruction. But if it is done at the age of 3, 4, 5 years, then it may need later on the pelvic osteotomy, which already I have showed you slides. The second test is stability. Hip is stable in internal rotation and abduction, internal rotation and lateral abduction. When there is a stability in internal rotation and dislocation in the neutral position, then this child only needs a derotation osteotomy. So because hip is more antiverted and it is reduced in internal rotation. So this antiversion is corrected by the proximal derotation osteotomy. But it is said when hip is stable in flexion and abduction, hip is stable in flexion and abduction, it means there is a superolateral deficiency, anterolateral deficiency of the acetabulum. Acetabulum is obtuse. So this child usually need a pelvic osteotomy, which may be a Pemberton, which may be a Salter or Dega, whichever, it depends on the choice and the indication as well. So if it is also in the internal rotation, then varus derotation osteotomy is also needed along with this. This group shows the hip is stable in flexion, internal rotation and abduction. Then this child needs a derotation varus osteotomy because abduction produces the stability. Then varus derotation osteotomy, and because it is stable in flexion and abduction, so he needs also the pelvic osteotomy. But when this hip is brought in the neutral position, as I already showed you, in this position, test of stability, so this comes out at the just mild internal rotation and neutral position, it comes out. But when it is in the flexion and abduction, it is stable. So this child usually needs both varus derotation osteotomy and the Salter's osteotomy. The third step is fourth step or position of the stability. You sometimes find a double acetabulum. Tonus 3 dislocations are very high dislocation. You find a very obtuse acetabulum and bump in between. And we have many times we've seen the bump, this bump in the double acetabulum irregularity. And the tonus 3 or 4 dislocation. Sometimes there is a mild caput, micro caput femoris and wide acetabulum. These are two indications when you do the acetabuloplasty. Mostly we do the Pemberton acetabulum, depends on the bone stock and the age. And some people, and we also do the Degas osteotomy when the age is more than 8 years with the double acetabulum to get the good coverage of acetabulum. And the other indication for the Pemberton osteotomy we will discuss when the more than 15 degree of acetabular index is needed. Then we do the Pemberton osteotomy. So the Pemberton osteotomy is in double acetabulum, irregular acetabulum instead of a Salter, which may not produce a good hip without bump when you do the Salter osteotomy. So therefore, in the fifth stage is this test of stability when you find double acetabulum. Sometimes many of the times in 25 to 30% in this European study, but in our studies, 50% cases comes to you with a tight reduction, tonus 4 dislocation, high dislocation, unreducible, age more than 30 months. Here you need to have an easy reduction only when you do the femoral osteotomy and the shortening. When you do the shortening and femoral osteotomy, you do the osteosynthesis and then repeat the test of stability to know which type of pelvic osteotomy you needed. In this shows mostly Kilsick approach and the Wenger's modification of Kilsick, which commonly do after 30 months of the children when the hip is tight. So here shows again the test of stability. In neutral rotation it comes out, but when little internal rotation, abduction, flexion, it is stable. This child was then needing a femoral derotation osteotomy in the pelvic osteotomy. So now the case example of capsular distal derotation osteotomy operation was done at the 19 month of age group, tonus 4 dislocation, and after 6 years this was the good coverage of acetabulum with just femoral capsulorrhaphy and femoral derotation osteotomy. I sometimes do distal derotation osteotomy to avoid the bleeding, significant bleeding and any infective process. Now, so derotation osteotomy and the capsulotomy give the good result at 6 years of age group. And this is the Butty's scoring system, which I show the Palthis. On this side, there's a little bit less abduction, the full excellent squat, and the Tashahhud position, those shows the incision for the this approach. And this is another girl with the femoral derotation osteotomy was done at the 18 months of age with the capsulorrhaphy, and good coverage at the 4 years follow-up, shown excellent hip joint and the Butty's scoring of Palathi, Tashahhud, and the squat position. So now the fourth part of this lecture is the pelvic. With the pelvic osteotomy, the objective of the pelvic osteotomy to improve the femoral head coverage, to provide the best cosa femoral stability, joint stability at the adulthood without deformation of femoral head. And there are three types of the osteotomy which are done. Mostly the reorientation or reconstructive osteotomies, in which we rotate the part of the pelvis, and we commonly call it the Salter or the Paul Decor triple osteotomies. Then there is the pericapsular osteotomy, in which we have the reshaping of the femoral acetabulum by doing the Pemberton and Degas osteotomy. This is the incomplete osteotomy. But sometimes in the later age groups, older age group, when you reduce it and multiple failures, sometimes you do the Chiari's osteotomy or shelf procedure of the stylies and acetabuloplasty. The reorientation osteotomies are the complete osteotomies. They redirect the entire acetabulum, and types described depending on the location and number of lines I will discuss. That is called the Salter's innominate osteotomy. Sometimes we call double osteotomy, and the triple osteotomy, which may be a Steele, Wenger, or Palcourt. Then the acetabuloplasty, they are incomplete osteotomy. They redirect it, and the hinge of this rotation is depending on the triradiate cartilage. So it is done before 8 years when the triradiate cartilage become stiff, and most of the time we do the acetabuloplasty of the Pemberton or the Dega, it is called. And Chiari's osteotomy is again an ilium, is the distal portion of the pelvis is pushed inside to shift the weight bearing axis medially and to enlarge the acetabulum by medializing the coxofemoral joints. And here is the Salter's osteotomy, and there are modifications of by the Kalamchi. The Salter's ossification goes from above the anterior superior spine to the sciatic notch, and here is the triradiate cartilage. Hinge for the Salter osteotomy is the symphysis pubis, and this symphysis pubis gets stiffened up to the 8 years. Therefore, it is mostly indicated below the 8 years of age, and most classically it is done by the Jiggly saw from the sciatic notch to just above the anterior superior iliac spine, and then stabilize the proximal fragment and pull down the distal fragment and place a graft here. That is called Salter's osteotomy. Triple osteotomy, Alpal, core, and the Wenger are nearly similar, depending on in the Wenger, the incision for the ischial osteotomy is given through the thigh, while the Polker give the single incision, and he do the iliac osteotomy, pubic osteotomy, and the ischial osteotomy, and these are then rotated. This shows the pubic osteotomy, and then they are rotated and placed a graft like a Salter and stabilized with the patient. This is my patient in which I have done the Wenger's triple osteotomy, in which the ischial incision is posteriorly, while in the Palcourt it is a single incision approach, ilioinguinal approach or iliofemoral approach. From this we do and then rotate whole of the acetabulum to get the good coverage. Then the Pemberton osteotomy is the short of the posterior portion of the it does not cross through the sciatic notch, but up to go directed up to the triradiate cartilage, and then this portion is directed downwards to get the superior anterolateral coverage of the acetabulum and placing the graft. And then there is a Degas osteotomy, little bit difference in Degas osteotomy in that both are Pemberton and Degas are meant to the hinge at the triradiate cartilage, but in the Pemberton we cut the whole of the ilium, leaving this part intact, sciatic notch, but here only the lateral table of the ilium is cut. The medial table is saved. And this is the difference. When there is a good bone stock, you do the Degas osteotomy, good anterolateral and posterior coverage also you can find and placing a graft, but you don't need a fixation with the K-wire. So to briefing which osteotomy to be done in what age group, the Salter is doing from 18 months to the up to the 5-6 years age group. Then the Pemberton start from the 3 years age groups to the 10 year or 9 or 8 years age. You can do the triple osteotomy when it is adolescent or teenage, up to the 14 years or 13 years age groups, and up to the 25 years age group. Then also the modification by gauze and the Chiari. Chiari is done basically from the 6 or 8 years age when there is a failed previous surgeries, or you are not able to get the good coverage. Then we previously used to do the Chiari osteotomy. Nowadays we don't do the Chiari osteotomy after the Pemberton, and the Dega we commonly do in placement of the Chiari osteotomy. So details of the Salter osteotomy: the cut is above the superior anterior inferior, directed laterally, cutting with the jiggly saw and redirecting with the acetabulum. Indications are the 18 month to 6 year. Hip is relocated concentrically. If it is dislocated, you should not do the Salter's osteotomy. And unstable hip on extension and adduction, stable in flexion abduction, acetabulum index when required less than 15 degrees. The minimum acetabular coverage when it is required, acetabulum correction of acetabulum, you use the Salter's osteotomy. The prerequisites are the concentric relocation, release of the soft tissue. They have a good initial reduction without pressure, good range of motion, and pubic symphysis should be mobile, which is commonly age group below the 7 years of age group. And here is the details with the animations. The cut, first cut is just above the anterior superior spine, the sciatic notch, directed downward and posteriorly. You will take care of the circumflex artery and the gluteal artery and the nerve here by the retractors. It is subperiosteal approach. And then you redirect this fragment downward, pulling the downward to give the anterior superior coverage, and place the graft like this, which graft is taken from this place, and then the placement of the graft, and then placement of the graft here, and then placement of the K-wire. While placing the K-wire, you must check these two K-wire should be parallel. It should not cross the cartilage of the acetabulum by image intensifier and or X-ray, or I usually do by both, by finger palpation inside the acetabulum. The tip should not be touching the femoral head or should not cross the cartilage, and the placement is vertical. This is the Salter osteotomy in again, which is a case example of the Salter osteotomy and 8 years follow-up. This was the case which I have done in 2012 December. The open reduction I have done here, capsulorrhaphy I have done there, and then the Salter's osteotomy, which is definitely indicated here for the Salter's osteotomy. And in this case, I have done the distal derotation osteotomy here to get the correction of anticurvaza, and the 8 year follow-up just last month. And she is in the Qatar and sent this pictures of the patients. They are regularly giving me these every 6 months and 1 year. They send me the pictures and the photographs. They show excellent reduction, but little bit short. Maybe she had an avian hair, short femoral neck, but the Bhatti scoring shows excellent results with little bit less reduction, which she said she is recovering. She has no pain at all. And this is another group of daughter of a doctor, which I have done at the age of 2.5 years. Tonus 3 grading, significant dislocation. Salter osteotomy was done and shows an excellent results on the Bhatti score. But unfortunately, she had 1.5 centimeter lengthening of the operated side of the hip joint, and this lengthening is usually because of the Salter's osteotomy, which brings down the femoral head. And we are waiting. This age is now really at 10 years now, maybe the 12 years age. We do the stapling of the hair for the femoral physis to get the good. This is common happening with the femoral fractures. Even you have seen at the 3 years, you can find 1 centimeter lengthening. And this was because of the Salter's osteotomy. So here is the Pemberton osteotomy, which is pericapsular incomplete osteotomy. It's not crossed through the sciatic notch. Here you can see the sciatic notch is intact, and it is directed up to the triradiate cartilage, and whole of the ilium is transected, and then the graft is placed here, and this shows the intact posterior sciatic notch element, which is thick. That's why it is called incomplete, and this is the redirection. Okay. So age for this is less than 7 years. because after 7 or 8 years, the triradiate cartilage could stiffen. Then incongruent or double acetabulum you find, unstable hip, relocation hip, moderate to severe deformity, means when the acetabular coverage is required more than 15 degree. And the triradiate coverage must be open, and very most versatile type of the dislocation reduces the acetabulum inclination. Acetal roof is rotated anteriorly and laterally. Triradiate cartilage is the hinge, requires good remodeling, because sometimes in the early X-ray you find little bit irregularities of acetabulum which gets normal with the growth stimulating effect on the long term and difficult to perform because it needs an expertise. So here is the detail of this osteotomy again from the Campbell's figures from the Campbell's, and this is the osteotomy which was done. Here is the example of 3.5-year-old child with a bilateral dislocation with a double acetabulum. This acetabulum, and then there is a very obtuse, more than 50 degree verticality, more than, if you do this is around 70 degree. This shows one acetabulum and this shows another acetabulum. So here is the hinge. If you do the Salter, this hinge will disturb and it produces a saddle type of femoral head, and that will be deformation which may produce an irregularity. So here we do the Pemberton osteotomy from here to here and give coverage like this. And this is the example of the height of dislocation, how much femoral head to be resected from here, because it is 3.5-year age and there is significant tonus height 4. So this is the example of the same patient after capsulotomy. You can find the femoral head and then the test of stability here. This is the acetabulum here, which shows the pulvinar and thickened ligamentum teres already been cut from here, and there is a pulvinar filling the cavity, and after removing this pulvinar you could find a good space here. And when you reduce the hip joint, you can reduce it after adductor tenotomy, but it is very tight, so you need a femoral osteotomy and shortening here. And this is the example of the, again, how to do the lateral box approach from lateral side, femoral osteotomy done here. And after femoral osteotomy, I pull the fragment and see how much this femoral segment has to be resected. Radiologically, this notes a 2 centimeter, but on the operator side, this shows 1.5 centimeter reduction. Osteosynthesis was done, and after osteosynthesis, correction of cosa valga and vice versa, you do the test of stability. So now see the test of stability in here. When in neutral, in the position it dislocates and it is stable in flexion and abduction. You will find this detail in the YouTube when you go click my YouTube and get the Pemberton. So dislocate, so she need and the Pemberton osteotomy I have done because of double osteotomy. This is the incision of the Pemberton osteotomy here, and it shows, this is the osteotomy, special osteotomy, which shows the mobility here of distal fragment over the femoral head. And after this osteotomy, you place the femoral graft here, and this shows the curved triangular graft after Pemberton osteotomy, which has been done. And this is the result of the Pemberton osteotomy. You find excellent coverage of the femoral head, which is up to the here, and on the both side, the complication of the Pemberton osteotomy means maybe an over coverage impingement syndrome sometimes you have. So this shows the Shenton's lines, inside coverage, distance between the teardrop to the femoral head less than 1 centimeter, and then it shows the how much osteotomy 27 degree and 26 degree has been achieved. So to summarize, the pelvic osteotomy is less than 7 years, Salter's osteotomy, Pemberton osteotomy, Degas osteotomy. Over 7 years, if triradiate ligament is open, Degas osteotomy, or tonus or steel or Paul osteotomy, triple osteotomy has to be done over the age of 9 years and 8 years. But if this age is 7 years, then triradiate is closed. 7-year triradiate is not open. Then directly the steel or rotational osteotomy, Bernese osteotomy, the Mansu commonly do this Bernese osteotomy, or the steel spherical osteotomy. But when all thing is failures and you need a salvage, then the salvage procedures are mostly the stylies. Sometimes there is a less coverage of the femoral head. Everything is going good, but little bit less coverage. Then you do the stylies operation, stylies femoral coverage, and the Chiari's medial displaced osteotomy. So here are the models of this Pemberton module, Salter module, and the Salter on the bone module. You can click in the slide share. When today I will do this. You click, you will get this video detail, and this all three are available. And if you do the youtube.com user One Ortho Jepis, you can find 20 lectures, which we already done along with these 3 modules. So I will not play the video today, but I will giving you the links this. So protocol over the age of 3 years, the last part. This prolonged dislocation significantly, there is soft tissue contracture, structural abnormalities, then you need a concomitant femoral shortening. And this is called one-stage combined procedure, which was introduced by Jinkonic, and the Kilesic, which was further modified by the two incision method by the Wengers. Here, single lateral incision was given, and the approach was transfemoral and inferior capsulotomy. This was modified by the Wenger in the 84, and 2 incision approach was introduced as the anterior approach, Smith-Peterson up to the osteotomies of the pelvis and the lateral subtrochanteric osteotomy. This is the Kilesic approach. Here you need the femoral segment to removal and goes from here to cut this psoas tendon and then directly go to the capsule and do the capsulorrhaphy, and from here they also do the Salter's osteotomy in the single incision, lateral incision approach, Jankovic and the Kilesics. And here is the detail again, and you will find, and this is one of the examples up to publication in 1997. You can find this 2009, and you can find the article cases, my cases which were done by the Kilesic approaches, and this is the 10 years and 15 years follow-up, which show the excellent results after this. And then the 2 incision approach was introduced by the Wenger, in which we do the femoral osteotomy through the lateral approach, and anteriorly the reduction and the pelvic osteotomies. And then these are the examples of 3 years in 2005, and this was the plaster which we used to give 3 years. Now I give only the 6 weeks plaster, and good excellent result after 10 years follow-up. Little coverage is less, so she may need a stylish procedure nowadays. This girl is 15 years age, and this is my 12 years follow-up of the same Tonus 4 dislocation, shortening and Salter, which I have done here 12 years back, and recent follow-up in October, in particular January when I was in Sakkar. After that I have never gone, show the excellent results of Tonus 4 dislocation and good coverage with the Salter's osteotomy. This is the 12 years follow-up, and this is the case which you already seen with the Pemberton, which you've done the bilateral single go operations, shortening and the Pemberton osteotomy. So case example, when you do not follow the last slides, you do not follow the principles of the management, you may deviate from the principle, then you have a devastating complication. The first slide I showed you, if you do mishandling, you will get the bad results. So this was the case which was dealt at the 3 years age by someone else, not by me. They given 6 weeks traction and gave the close reduction, and then place the K-wire, and then the cast. This redislocated. This was the case. Previous X-rays are not available. The first redislocation after close restriction, 3 years age it was done, and at 6 years, by she came to again the same surgeon, and what he has done again same methodology. Open reduction he has done, capsulorrhaphy has done, but age was more than 6 years. He must have done the Salter and the femoral shortening, but he opted to place a K-wire, which withdraws in due time, and this shows the double acetabulum, but hip dislocates again. So at the 9 years of age group, she had this type of dislocation or double acetabulum irregularity. This is particularly a clear-cut example of deviation from the principles. So again, the same surgeon has operated, done the open reduction, derotation osteotomy. Here he has done. He got good results with this K-wire placement, but he has not done the pelvic osteotomy. So instability was there. And this luckily child continues with this type of the triangular femoral head, and at the age of over 9 months or 12 years age group, now she is 21, she got severe osteoarthrosis of the hip joint, gross disability and shortening, which you can find, and this is the lifelong complication. She will need the total hip replacement. This is 15 years age when she was reported lastly to me, and we advise him to have a THR. So this is the last at the 20 years age, limited, significant osteoarthrosis, fused, everything is fused and shortening. So when you deviate from the principles, you have a lifelong complaint, that is the devastation. So what is the treatment outcome factor? So treatment outcome factors, we already discussed the age groups, quality of initial reduction, which must be best, and the surgical expertise. You should not deviate from the principle, and the patients and relatives compliance to the treatment for physiotherapy and the long-term follow-up. These are the treatment outcome factors. Is again the summary for the which procedures should be done: pelvic harness below 6 months age group, and fixed harness after the 6 months, or closed reduction tenotomy, and the open reduction with the assisted arthroscopically. And then if they comes with after 18 months, they need a Salter's osteotomy open reduction, and sometime in the older age group femoral shortening as well. But after 3 years, they definitely triple procedure, they need open reduction, femoral shortening, derotation, and the coverage for the acetabulum. But when they come after 6 years, they need a Degas osteotomy, Bernese osteotomy, rotational osteotomy, along with open reduction and femoral shortening. So take home message is there is no shortcut in the surgery, no tight reductions. But if you follow the principle, you can carry a 18 kg weight because you follow the principle given by the master. So good initial reduction is very important to follow the principle and later and splits. This lecture is dedicated to my mentor, Professor Saghir Ahmad Khan, the first TKR workshop in 1995 in Pakistan at JPMC. And these were his mentees.